I have the pleasure of introducing Dr. Nancy Loos. Her biography is in your program, but I'd just like to read just a little snippet. Dr. Luce is passionate about professional role clarity, quality nurse-patient relationships, safe patient care, improving communication skills to good documentation. She has co-authored a book chapter with Dr. O'Rourke entitled Professional Role-Driven Leadership: Impact on Operations. It was just released in July 2023 as part of the book Mentoring in Nursing Through Narrative Stories Across the World. And you've also completed a chapter in another book on implementation of the theorist Imogene King's work, and that will be published in early 2025. Thank you, Dr. Luce. Please come.
Good morning. And where's my Texas peeps here? Okay. I'm a New York girl and I haven't seen lightning and thunder for a really long time. So I should say seen lightning and heard thunder. So thank you for that. I absolutely loved it. And to see the rain, it's like, oh, California, we need it. So I was absolutely thrilled with that. So I have to tell you that I was still a staff nurse in the ICU in the mid 90s. And I had the great fortune that I had a CNO at the time who brought in Maria, Dr. O'Rourke, and I listened to. We had, I don't know, it was a long series of lectures and classes, and all this. We heard all this, and to me, it was like this makes so much sense. Of course, this is what I understand, but I couldn't have articulated it. It was very real to me, and it was I absolutely said, I understood every little bit of it, but I finally, after going through all these things, you hear it once, you get it, but you need to hear it multiple times to really get to where it wasn't until I started teaching it, honestly, that I was able to say, absolutely sing the song full on. So if it takes you a few times, that's okay. And when she came back, what, a decade later, that's when I started working with her and for her. And it's been a passion of mine, which then led to when I was doing my doctoral work. It was foundational to what I decided to study. And where's the clicker? Here it is. Um, so everything, once you get it, everything that you think and everything that you do is predicated upon this as a basis. Like you start seeing things through this lens, right? So I did, let's see, forward. Yeah, big green button. Good. So nurse listening behaviors, it was something that kind of came upon me. There was an actual clinical issue, which I can talk about it now, but um, I was the director of nursing operations at the time, and we had very low scores on our HCAPS. And for you out of the country, I'm not for sure if you understand what HCAPS is, Poland and Australia. It's any hospital that takes CMS funds has got to give a survey out to patients when they're done, and it's about the patient experience. We used to call it patient satisfaction, but I want to say it's not that. We haven't measured that in 15 years because that was a prospective thing. Like people come in with, I have the expectation that this and this is going to happen. Well, who can deal with that? You can't meet everybody's expectation. Patient experience, on the other hand, looks after the fact and it's quantitative and it says, how often did we do what we said we were going to do? And it's a much better way to rate. People hated patient experience, patient satisfaction, and I don't blame them because it was undoable, right? So we had HCAP scores around nurse listening. That's one of the things that is measured in this study. And we had our nursing units, our med-surg units particularly, were very low, like honestly, the 5th percentile or something like that. And I was given the mandate to raise these scores and you have a month. Okay, right. So I looked in the literature and what was there was not much. There was nothing about about nurse listening behaviors. What am I supposed to tell my nurses to do? So there was a lot around other, relationships, the doctor and the patient in the doctor's office, things like that. So anyway, I decided to go forward with that. And I thought, well, I can only do what I can do now, but I should study this. And so that became my doctoral work is what does nurse listening look like? What are those behaviors? And those are all, of course, based on as being part of a professional role that we do no harm, we do this, that. And surely listening has got to be one of the things that matters if we're going to do no harm and all the other things that we're supposed to do. So now those listening behaviors and conversely, non-listening behaviors have been defined. It's in the literature actually now. So this this model in mind as we go through this, and you've seen it a number of times today, but I want to reinforce the fact that this whole blue diamond this is you. This is you, and all these sub pieces are what makes up you as somebody in a profession. So you are a leader and a decision maker. You are somebody that transfers knowledge. You are the practitioner, and you are the scientist. You come with all those pieces. And as Dr. O'Rourke said, if you don't want to do the science, then you need to find something that suits you. And you may not even realize how much is based on science, on scientific evidence that even when you give pain medications, that's all based on theory and science, etc. So we today I would like to enforce what the professional role obligations are, and we're going to learn some of these nurse listening behaviors, and I've published article about it, and you can get it, and they're all laid out, and they're very practical, and they're things that you're able as management to tell your nurses, share with them, and as practitioners to do yourself. And I only studied what it looks like in an acute care setting with a nurse, and this is from a patient perspective, what those nurse listening behaviors were, but it can be extrapolated to other situations as well. And I'd like to connect these two together. So the professional role and its obligations. And I know you were asked how many, and I didn't see, how many of you actually did look at your Nurse Practice Act in your schooling? Yeah. Okay, that's more than I usually get, honestly. I honestly don't remember seeing it in my nursing. That was a long time ago, but I don't remember doing it. And then they're legal. It's legal obligations that are enshrined there. So, I mean, if you don't know it, how are you supposed to know to what you're practicing? To what legal level you're practicing? And then, not only do we need to practice to the law, but we need to practice to our professional obligations as well. And so, being in a profession, we have three levels in nursing: the professional role, the RN, the technical role, which is the LVN, and then the assistive role, which is the nurse's aide. And all three of those work together for the patient experience. So we're going to look at these important things. So again, here is this role, and we're going to focus on the, communication, which, stands out as, oh, that's the transfer of knowledge. But I'd like to propose that that's every piece of this, the leader, decision-making scientist, and the practitioner, it's applicable to those roles as well, or to those aspects of the role. So the thing about communication and transferring knowledge is, and this is huge, it's not a one-way download of information. The transfer of knowledge goes both ways, and it is ever so important for the nurse to listen to the patient, whether that be the words that they say, the words that they don't say, the body language that they have. There's a lot of ways to listen, and all those things, because not only did I study what the behaviors were for listening and non-listening, but I also looked at what the outcomes were attached to both. So the outcomes of having been listened to and the outcomes of having not been listened to. And they were massive, and they surprised me, actually. So the transfer of knowledge is, only one aspect of it, but the mandate to listen, like as I said, is involved in each one of those. So we're going to first look at what it's been mentioned, what the California Nurse Practice Act says, to see if we can see there why there might be listening involved. So I've highlighted a little bit, but the functions, and I've bolded, but I've also yellowed out here. So you see science, you see practice with the technical skill, you see the observation, determination of things. So when you determine whether the signs, symptoms, and reactions, behaviors are normal or not normal, you're now in the decision-making process, right? So you're now have to make a decision of whether to, implement something, report it, refer it. So that's all embodied here in this, oh, I'm sorry, in this practice act. So you can see this is it was written in 1974, came out in 1976, but it's a living document that continues today, and it's easily applicable to anything. I love this practice act, so I really wish we had studied it. So I'm going to now look at just Texas's Nurse Practice Act, just because we're here, and why not? And I've highlighted for you, so a substantial specialized judgment and skill. So you have the, specialized education, which isn't required of a profession. You have your skill, which is your practitioner piece. You have the science, which is the third highlighted piece. You have observation assessment, the teachings, the maintenance, the supervision and teaching of nursing. So these things are not just for the practice at the bedside. This is also for every aspect of role that every clinical, every functional role that you take. So whether you're a clinician, a manager, a researcher, whatever, you still don't get to not do the rest of this stuff because you're still an RN, no matter what functional role that you're in, which I think is important to know. So have you, Texas peeps, have you seen this? And oh, yes. Do you teach it or do you? Oh, okay, good. So, you can compare and contrast the two, but this is what you practice here in this state. So, the transfer of knowledge, and you'll see transfer and transferer. Like here, I have transferer because the transfer is the act and transferer is who you are, right? So you're the one doing the transferring. So we'll focus on this because this is the most obvious one linked to nurse listening, right? So the behaviors that are listed here are not the whole, panoply of those behaviors that can be done and involved in a listening transfer of knowledge situation. But active engagement means the patient or care team knows and believes that the nurse is present. So and this is what I found, if the patient doesn't believe the nurse is listening, they're going to close down and they're not going to share. And we cannot actually make decisions in their best interest if we don't know how they feel, what they're thinking, and what their concerns are, what their fears are, et cetera. So active engagement means a two-way street again. When communication is aborted or stifled, this can lead to error and lost opportunities and a loss of trust, which is huge. Once you lose that trust, you've basically lost the patient to an open relationship. And every encounter that we have is an opportunity to, to assess, to teach, to reinforce, to invest. We don't have to wait and silo these things into separate. Now I'm going to assess. Now I'm going to invest. Now it's every opportunity, every interaction that we have with them is an opportunity to do all these things. So we need to ensure the knowledge transfer at every interaction and every encounter, and teaching shouldn't be set aside, for instance, for a time, it's always every time we interact with them, we're teaching. So what is communication? Okay, there's a lot of different definitions, but the best summation from literature that I like is successful conveying of sharing of ideas and feelings. So you can think that you've shared it, but if it's not successful and it's not actually taken and understood, it's not a successful interaction. So listening helps you understand the perspective of the communicator and effectively engage with them. We know this as human beings. This is not just in a nursing role, right? This is in your marriage, with your kids, with your friends. This is important to know for communication. And again, it's more than just talk and gestures, of course. It's listening, understanding, and then interpreting as an integral to part of communication. Words, verbal, written, gestured. So I did look at both verbal and nonverbal listening behaviors. And the patients, I'll tell you, the patients had a very difficult time explaining to me that what behaviors the nurse did that showed that they were listening. They had no problem at all telling me about the behaviors that they said the nurse was not listening to them. They could pull that out right away. But then that listening, it's just expected. And it's what you just get a sense as a human being when somebody's listening to you, right? But so it would be, oh, they're nice. They were there. We had to really pull it out of them and get them to think about what that looked like. So there are basically listening is important. So we need to know what are the behaviors that convey listening, how do patients react both when they feel listened to and not listened to, and is the ability to listen innate? Do you think it is? No, it may not be, and it isn't, but it's foundational to nursing. But the good news is it can be learned. So we don't have to give up on our role just because of that. So there's listening, nonverbal, speaking, thinking, and each one of those is important. So do we have a mandate to listen well? Is that part of our Nurse Practice Act? Is that part of our professional role? Well, the answer is 91% of consumers confirm patient experience is extremely or very important to them overall. Okay, this is a lot. Not 69% of them believe a good experiences contributes to their health and good health outcomes. The three most important factors influencing their experience is number one, being listened to. If this isn't validating, it's crazy. Communicated to in a way they can understand, and three, treated with dignity and respect. And the reason why I put that little arrow there is because I think that if you treat them with dignity and respect, you're going to listen to them. And when you listen to them, they're going to feel like they're being treated with dignity. I think that they're connected. So, and you can see the consumer priorities is people. That's the top thing. People, second thing, process, and the third thing is place. They they expect the place to be nice. They expect the process to work. But number one, if that relationship isn't there, they're not going to be, they won't have a good experience. So it's a little fuzzy because I had to blow it up, sorry, but this is the highest ranking patient experience components. Listen to you, 95% found it very or extremely important. That's huge. So do we have a mandate to do this? I'd say that we do. So you've all heard the To Err is Human report, 98,000 deaths per year, the 2010 from the IOM. And it's kind of shocking that we cause these deaths. And what do you think? I mean, most common cause of medical error is communication. So if we're not listening and we don't understand what's going on with them, and we don't know how to transfer knowledge, not just to the patient, but to our team members, the physicians, our coworkers, a change of shift report, whatever, we're part of the problem and we could be causing harm. 85% of that is nonverbal. That communication is nonverbal. And that's huge. So just be aware of that. And so HCAHPS, in case you've never seen the HCAHPS survey, here you go. You see that it says during your hospital stay, right here, how often did nurses treat you with courtesy and respect? And the second one is listen carefully to you. So it's a patient perception, right? This isn't quantitative. This is qualitative. How often do you think? Never, sometimes, usually, or always. So that's what we get rated on, and that's what the hospitals get reimbursed on, is the scores for these things. So it's a major big deal. And these same questions are asked of physicians, but nurses are the ones there 24/7, and the only reason people need to be in the hospital is nursing care. They can have everything else done somewhere else, right? So what nurse behaviors convey that listening is occurring? This is what I found. So these are some of the things that if you just look up, this is what you're going to get in the literature. But key concepts from the literature, I'll tell you what I found. But this is Stephen Covey. I don't know if you know him. He's the kind of the guru of, what do you call it? Organization and stuff. Most people do not listen with the intent to understand. Most people listen with the intent to reply. And once you start with that, you're going to shut down who's ever on the other side of that because they're going to be just, they can tell that you're ready to get in there and that you're not listening to the whole thing. So, listening from the literature, one of the most problematic communication skills. Yes. It encourages healing, and I did find this to be true. Is foundational in a trusting relationship. I mean, think of just your own personal relationships, right? Is an essential attribute of a skilled nurse, and again, can be learned. Is valued more than clinical competence. People come to the hospital expecting clinical competence. And so then the listening is more of an art form, I would say. Then caring, that's the other thing you'll see in literature. It's linked with listening. It's established through verbal and nonverbal communication. And yeah, okay, I have a quote later, which I'll share with you. So, how? So, verbal, reflecting feelings. I can see that you're feeling that way, posing clarifying questions, asking them, not interrupting them, which is really hard when you want to get to the answer. And many of them are taking a long time to get there. Paraphrasing, which helps. And then the nonverbal, nodding. And I would, a little caveat with that is I've had people nod while I talk. And if they're doing it too much, I feel like they're wanting me to hurry up and get done. So, be a little bit careful with that one. Looking attentive, that's in the literature. I don't know how, is that, uh, I don't know how that looks, but you'll have to figure it out on your own. Yeah, leaning in, which you've heard a lot about in literature lately. Eye contact, and again, a caveat with that is not all cultures like that, right? Especially if it's female, male. So you have to be a little culturally competent to know when to do that. And the why, this is the quote I wanted to share with you. Being listened to and preserving integrity reduce the risk of errors and omissions of care. And if we're not about that, I don't know what we are about. So absolutely tied to listening, of course. So behaviors that patients perceive as listening. These were my results. This is what I found with people of kind of all over Southern California with different religions, different backgrounds, different ethnicities, different ages, although I did do only from 50 years old up. I had to specify a population. And the other thing that I was told was that I had to keep it to people who had been discharged from the hospital. I did it after discharge because I didn't want them to be answering about their nurses while they were still, there was a power differential there while they were still under their care. So I did it after. I was told to keep it to 6 months because they would forget. They brought up, and I did, but they brought up things from 50 years ago. They brought up times when they did not feel listened to 50 years ago when they were having their baby or whatever. It doesn't go away. So making a connection was their biggest thing. I know you're busy. Just make a connection with me first thing in the morning and your day will go easier. That's the kind of thing that I heard. So this is what they said, eye contact it and attentiveness. Oh, and one thing that takes away from the attentiveness they feel is looking at the computer the first thing when you go in there. That was most of them said that. If you go in and you may say you're listening, but if you're doing this while they're talking to you, they don't feel that you're listening. So they want you to just give them that kind of unobscured time at the very beginning. Asking questions and personalizing their care. So you don't know how to personalize it if you don't ask them about themselves. And it could be just personal questions, but they felt connected then. Stop doing other things, and that was related to the computer. Look at them, not the computer. And they understand that you do have to be on the computer. And eventually that's great. But if you can explain to them, like Maria was saying, is talk out loud and talk your practice, talk about what you're doing and say, I'm doing this now because I want to make sure that I get down what you're saying and I get it down properly. And they'll appreciate that. They're not going to give us cues that we need to make our decisions. We have this decision-making authority and we won't be able to use it because we won't know what we're working with there. So, and then taking nothing for granted. So non-listening behaviors, which are the ones that they had no problems coming up with. And here I have 4 categories here. One is arrogance, not believing the patient. Again, they don't understand why we don't. Dismissing their concerns as unwarranted. And then I had abuse of power. It seems kind of crazy, but if you see these rejecting their input, to me, that's putting you as I know better than you. It's really kind of hubris. Arguing with the patient, yes, they all had people that argued with them and said they basically didn't know what they were talking about. Not trying to understand, they get very frustrated. And then instant incivility and insensitivity, lack of eye contact and rolling of the eyes. They actually found nurses that did that. Focusing elsewhere on the computer. And then what I call the abrogation of professional role responsibilities. No follow through. I mean, it is up to, we have to follow through. We have to measure what we've done, right? So lack of presence or awareness, not assessing the patient readiness. Patients would say, I got all this stuff dumped on me on my way out the door, ready to go home. I was not I was not ready to receive all that. I didn't understand it. So I just shook my head. I said, yeah, 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 I got it. And then I read it all when I got home in the next week. But meanwhile, there's stuff that you needed to know today. So we have to assess their readiness. So in my California Practice Act, and I love this piece, we are there to ensure the safety, comfort, personal hygiene, and protection of the patient. So all these things, they're not separate necessarily. There's a lot of overlap there. Once you assure the protection, you've assured their safety. Once you've done that, you've assured their comfort. So these were kind of drivers of what our behavior should reflect. So how did it affect the patients? Listening. Well, oops, sorry. So listening. If we listened, they felt a sense of security. They felt safe. And they would even say, I was able to sleep. I could finally go to sleep. I could trust that they had my best interests at heart. Mental and emotional well-being, they felt more relaxed, less anxious and calmer. Comfort and physical well-being, they had obviously feelings of comfort if they're, pain. Even if we couldn't get rid of their pain completely, it was like we set a realistic expectation of what that pain level could be, and they were okay with that. The non-listening, they felt vulnerable. A loss of trust, they were scared, upset, fearful, insecure. They questioned the care quality and they lost confidence in the care. Then mental and physical harm, they actually did have physical harm. Some of them had worsening, numbers, exacerbation of their condition. The situation worsened. They were frustrated and anxious. And then feelings of abandonment, which is antithetical to who we are, anger and resentment, ineffective treatment, and subpar care. So I'm going to give you some quotes later from some of the patients, but this was, generally, you can see the difference between what listening, their perception of listening, and their perception of us not listening. So I feel like we need to do whatever we can to assure that they know that we're listening to them. So here's some of the quotes in their own words, what they said for listening. I was more relaxed and less anxious. It made me more serious about my recuperation and not go rogue on them. That was great. He's like, yeah, if they didn't listen to me, I didn't care. I was going to do what I want. But this, he felt respectful and wanted to do. He respected what was being offered to him. I slept. I actually slept. I don't worry as much. Not listening. It made me feel like, oh my gosh, I must be pretty bad off for these people to be rolling their eyes and talking another language in front of me. And this is somebody who'd had a stroke. And so she couldn't respond and couldn't act on what she was feeling. It leaves a bad taste in my mouth about the profession. And I'd hate to think that what I did reflected on a whole profession, but indeed it does. While you're at the mercy of the nurses and they don't listen, it's kind of frightening because it's really up to them to take care of you. And it made my situation worse, which is antithetical to what we do and who we are. I felt like I was going to die in her care. Can you even imagine? So, does listening, is it a role obligation? Yes. Does it matter? Absolutely, it does. So, let's see. Why is it not going? Oh, here we go. So, as I said, once you learn the professional role, you see everything through that lens, and which is extremely helpful. And I have to say, I'll back up a little bit. When I first heard this and I was at the bedside, I got it, but it wasn't until I was in management and I was now at the union negotiating table where I had the language to say what I wanted to say. We had a much better interaction and we got to a contract faster because I didn't have, it wasn't about my opinion. It was about what's in your practice act and that you can't argue with that. So, and your professional role. Once you understood that, and it was great because I think you suggested that the union reps all and all the management came to all these sessions. And so they understood it too. So when we had a mutual understanding of what the professional role was, there was less argument about what should and ought to be done. So anyway, you see everything through this lens at that point. So as seen through the lens. So as a leader and a decision maker, we make decisions in real time. We do no harm. And so you can see that if you link that to the professional role as service orientation with public interest, decision-making capacity and leadership. This is all part of being in a profession, and ethics-driven practice. So we are only going to make decisions that are ethical and that will do the best for the patient. We're not going to make them in our own best interest, in other words. As a scientist, here we are, systematically gather and use research and evidence, and that includes from the patient themselves. What are they telling us about themselves? That's evidence. And we gain and share understanding and knowledge. We use theory, science, and evidence-driven practice, and you see that all there. All these are linked with listening. We can't make decisions without listening. Well, we can, but they won't be the right decisions. And we need to transfer knowledge, theoretical and practical. As a practitioner, of course, this hits service orientation and public interest. We say to do no harm. This is what we've pledged. Autonomy. And I think there's not a lot of understanding. I've done research on this. We have autonomous practice. There's a lot we can do without physician orders, right? There's all of the nurse sensitive indicators, all those outcomes, those are all based on nursing independent work, right? It's keeping the patient safe. That's in our job. That's in our professional mandate. So now what? Has your awareness been raised? What do you want to start changing today? You have some new information, both as a professional role and specifically around listening. So, and again, I'll give you the, let's see, where is it? You can see the fourth bullet down here in the references is, well, that's my dissertation, but I can give you, I've published it in Jonah, and it's very specific lists of what the behaviors are, and so you can get it. I didn't list them here so much, but I can get you two more, and I can give that to Tarek right later. And if you're interested in that, because they're very practical, they're something that you can tell them to do. So what now? I thank you for listening because you're very attentive. And so what now? How do you want to change your practice? What can you do starting today with this new knowledge that you have? And do you have any questions is the other thing. Yes, thank you. Thank you.
Hello. Okay. She was talking about formative experiences that led us to who we are. And I can think of every single moment in my life where I had a family member or myself that was a patient and I wasn't listened to. I don't think I had a single positive experience before becoming a nurse in which I felt listened to, or I felt that my family member was listened to. And that made me who I am. And that made me so passionate about listening to my patients. And something else that you said was they care more about listening than competence. But I would argue that listening precedes competence. We have to listen to our patients to be able to advocate for them, even if we don't know what's going on. We don't have to be competent in knowing what's going on to listen to them and to escalate their concerns. And the other comment that I wanted to make was to say that I would probably take this forward because I'm a nursing professional development practitioner. And I would like to educate more on listening. I've been a preceptor. My background's all ICU, and I've been precepting for a long time teaching. And, one of those things that I think I passively taught was listening, but I've never thought about actively teaching it. So I just really appreciate this lecture. Yeah.
What you remembered was not being listened.
Yep.
You don't remember, you're not coming up with behaviors of why, when they listen to that's effective, but when you weren't, and you stayed with you.
Yep.
And you're not the only one.
Yeah.
I'll tell you that about 5 of my cohorts in this study were RN who had been taken.
Yeah. And I think as women too, we tend to be dismissed a lot. And so I think it is just something that a lot of us have dealt with when we've been on the other side.
Well, the nurse knew what to expect, and they were ones who had good sleep, brains that, one of them, like, one of them, she's a nurse, and then she was a PA after that. But she knew the physician that made the order for her to get not an oral after she had had some throat surgery, but to have an IV, and they didn't believe her. And they gave her an oral. Like, she argued with them and said, "I know that. Get the chart, look at it." And they wouldn't do it. They gave her an oral. She vomited over everything. She, messed up her sutures, and she said, but even the nurses were afraid to necessarily stick it to, because they were afraid what was going to be done to them. I mean, that's a horrible. Can you imagine a nurse that even knows this was even afraid? So all 5 of them had issues like that.
Yeah, and I had another instance when one of the many where my baby was not latching when I had him, and they wouldn't give me formula, and I had spent 2 days trying to get them to give me formula. And I'm a nurse, I can advocate for myself, but because they weren't listening and they would give me so much pushback, I thought, I guess I shouldn't be this difficult patient. And so
Exactly.
they bully you into into not advocating even when you know better.
That's exactly right. And, they probably had their baby friendly or whatever, but there's some point where you have to, make practical decisions about, am I going to stick to, this kind of policy, or am I going to make it individualized to the patient? So they didn't do that. I'm sorry you had to deal with that. Yeah.
He's okay now. He's 5.
Oh, yeah.
I have a question. This is something I focused on early in my career as a young nurse leader. We looked at nurse communication with HCAPs, and we found some studies, but they were older, so I wasn't sure if you found anything with perception of listening and time spent with the patient when you were sitting versus standing. Was that anything you looked
Yes.
at?
Okay. And I didn't add it to this talk, but so the only thing I found in the literature before I did my own study was about sitting. It wasn't about nurses and patients, but it was about sitting. So I thought, well, I'm going to at least try that. And we called it sit for a bit. And so we instituted that in this, especially we picked one unit that had like the first percentile, sit for a bit. And again, we told them, don't add anything to your day. Do this while you're doing something else, while you're in the morning assessment and you're greeting them, whatever, just sit. And the scores went to 84th percentile in the first month. I'm not kidding. And so then it was like, well, we don't have a place to sit. So then it was like, well, we need chairs. Well, if you get chairs, where are we going to put the chairs? Well, then if you put the chairs on the wall, well, then they need to be reinforced. I mean, it was like we then had to go through this whole litany of things to get that, because there was linen on the chair, or it's dirty, or you don't want to sit. And so we had to keep working to take away the barriers to just sit. And so we did a little experiment, and we showed a video. We had one of our staff do a thing with sitting and listening. We did the whole thing. And we showed it to people without letting them look at their watch. We said, how long did that person just spend in this video with that patient? And they're like, 10 minutes. It was like 3 minutes. But they felt it. So, and that's why you'll see sometimes people in restaurants, your waitresses, waiters, whatever, they'll kneel down because they get bigger tips, right? It's shown that they get bigger tips. So people will think that you've spent way longer, maybe a third or half, again, as much longer than you actually did. So yeah, thanks for that question. Yeah. Anything else? Yep. We have. Yeah.
Pretty loud.
Well,
Okay. So there's a book called The Culture Map by Erin Meyer, and she talks about the different aspects of culture that really inform communication. And it can be very helpful. I mean, we really live in culturally diverse communities in most of our healthcare centers and academic centers. So I have found it very beneficial. It was very intriguing to me, and it's an easy read, maps out different behaviors and kind of tells you where the culture, like where they fit on a continuum. So it's a great kind of reference book.
That's fantastic. Thank you for that. I mean, we had a patient one time who it was from a culture who he didn't want to know anything about his diagnosis or anything. He just wanted his family to know. And that's a whole different paradigm when you're working with that because we're like, you need to make your informed decisions. We need to tell you this stuff. But he was like, I don't want to know it. And it's anathema to us to want to just tell the family things that, we feel like that's his prerogative to tell them, but that's what he wanted. So we had to be sensitive to that. And that was part of listening to what it made him feel better. So
Thank you.
I think it's on.
Yeah. So I wanted to put it within the academic environment for just a moment, this idea of listening. And recently, I attended a session where a couple of professors had done a study on what they called learning proximity. And it had to do with whether or not the prof is standing like up here, or if the prof is circulating the room. And they discovered that, and what they were measuring was engagement with listening being an aspect of that, and discovered that proximity mattered. And that students had very high regard and higher engagement and felt more listened to when the professor was circulating. It also mattered, I wanted to say that their other finding was how close in proximity also was an issue. So if we're, yeah, I think for all of us, that if somebody's too close for too long, so there were some nuances, but essentially engagement improved with proximity.
Well, can I go back and re-give this talk while I wonder?